السلام عليكم ورحمة الله وبركاته. الحمد لله والصلاة والسلام على الحبيب المصطفى. شكرا جزيلا للجمعية السعودية لأمراض الروماتيزم والشركة المنظمة for the invitation. أنا عارفة إن ضربتين في الرأس توجع، فأخذت باثولوجي والحين PFT، بس I promise you it's not a hit on the head إن شاء الله. طيب, so I'm gonna go over a pulmonary function test, and I'm sure my rheumatologist colleagues have a very good understanding for this very important tool in clinical practice. Interpretation of PFT results, the role of PFT in monitoring of the disease in general, conclusion and future perspective. So what is PFT? It's a general term, pulmonary function test. When we say so, it could include spirometry. We're going to go over that quickly. Lung volumes measurements, diffusing capacity, even arterial blood gas is a PFT. Even the walk test is a PFT. CPET is a pulmonary function test because you want to see how strong the lung functions is. The FVC is, simply speaking, the amount of air the patient can exhales in or exhales out or inhales in with forceful effort. Whereas the DLCO is, it detects the ability of the lung to extract blood, oxygen from the blood, to the blood from the air and diffuse the CO2 back to the alveoli. The lung volume measurements, it's the total amount of air in the lungs. In the graph, so this is the tidal volume. This is what you are currently breathing in and out very calmly. This is tidal volume. When you take a deep breath in, so it's the forced inspiratory vital capacity, or exhales out. Again, it's the exhaled forced vital capacity. It's the add-on to the tidal volume that you're doing normally. If you exhale all the way out, what's left in your lungs is residual volume. Whereas after the tidal volume, you breathe in and out, what's inside your lungs is called FRC, functional residual capacity. As the name denotes, it's the function, is exactly the amount of air where the gas exchange occurs. All of these are the total lung capacity, which is one of the interests of our talk today. So spirometry, it's assessing the flow against the volumes. It can determine in few seconds how much the patient can exhale out. And we are interested in the first second. It's like the tap water. How much of air can be exhaled in the first second? It should be the majority of air should be exhaled in that timeline. That's why al-bast wal-maqam should be normal, right? FEV1 over FVC should be normal. Thus the ratio should be normal. If there's an impairment, so that's a normal flow, or volume against the time. If there is an obstruction, the FEV1 is very small in relation to the FVC. The patient eventually will be able to exhale all the air out, but how much he exhales in the first second is reduced. That's why the ratio is being reduced. And this is usually the graph as illustrated in the volume time curve. Whereas in the restriction, the patient has no problem in exhaling the air out. It's the problem in getting the total amount of air. It's reduced in total. It's like the container. Your container is smaller. It's not about how much you can get out of that container. So ultimately, the ratio will be normal because both the FEV1 and FVC are relatively reduced at the same ratio. And that's the hallmark of restriction. But you have to calculate TLC. You have to have a full lung volume assessment to determine that the impairment in the FEV1 and FVC is not related to severe gas trapping, which is one of the tricky findings in interpreting pulmonary function tests for non-pulmonologists. So a simple approach, you would do the ratios, FEV1 to FVC. If it's reduced, obstruction, simply. If you go to the ATS updated guidelines, it's so confusing. Please don't do so. This is a very simple one. So it's obstruction. If it's normal, the ratio, or high, so that can be a normal test, normal lung functions, or it can be abnormalities in the lung volumes determined by the bloody body box bismography to check the lung volumes, the total one. And then you would determine if it's really a restriction due to a parenchymal etiologies, the lung is fibrotic or inflamed, that's why it's not expanding, or it's what we call extraparenchymal involvement. The lung is fine, it's not a diseased part, but it's because the chest wall is very restricted from kyphoscoliosis, the muscles of breathing are very weak, or there is extensive pleural effusion, for example, preventing the normal lungs from being expanded. There is a special evaluation in PFT to determine that by measuring the KCO, what we call KCO. But that's, I'm not going to go over that for this talk purpose. So how the CTD, pulmonary involvements, and how that translates into lung physiology. The ILD can be inflammatory versus fibrotic, and very crucial to understand that, because your goal of treatment, if you are treating a fibrotic ILDs and the fellow jumps to you and saying, Doctora, the FVC has not improved, fine, better. Doctora, it declined, okay, good, but how much it declined? Whereas if it's inflammatory, you can have a resolution of forced vital capacity. So if you don't understand the goal of treatment based on the underlying physiology and pathophysiology of your diseases, you're gonna overcall or undercall your physiology interpretation. The obstructive lung disease is very commonly involved in CTDs, in particular rheumatoid. And the involvement of the medium or small airways, giving a bronchiectasis, which is easily seen on images, or the more subtle changes such as a bronchiolitis. Patients with rheumatoid can present initially with bronchiolitis, and it can be bad enough to the form of constrictive bronchiolitis, which has a very poor response to treatment, even intensive therapy. And the clue to that is to pay attention to the details of PFTs and to get an HRCT with expiratory image to detect the gas trapping. Pleural thickening and effusion can be translated into extraparenchymal involvement and pulmonary vascular disease, pulmonary arterial hypertension as well. So the PFT abnormalities, it's either going to be a restriction due to ILD, restriction due to chest wall movement, impaired gas transfer capacity due to pulmonary hypertension in isolation or combination with ILD. So what's the diagnostic value? What are we actually doing at PFT for? So it's either we want to detect the lung involvement early during the disease course, or after the disease already been established, we want to monitor the disease course, or even we want to assess the treatment efficacy. So I'm going to go over every box for these in our next time. So starting with the early detection of lung involvement. This is a nice graph summarizing the SSC-ILD trials in the last years, and it evaluated which PFT parameters have been used from DLCO, FVC, TLC. This is the ones I'm interested at. If you look here, initially the DLCO was the primary outcome of CTD's ILD and in particular SSC ILD trials. In the mid-20s, there is an increase in the peak of use for these two outcomes, and short after there is the FVC surpassed the DLCO as being the most commonly used primary outcome. And if you look at the cumulative or percentage cumulative, which calculated according to the cumulative use of each PFT measure, divided by the cumulative number of published articles, again, it gives you the same increase in FVC with the peak in the mid-20s, or 2000s. So what do you think has happened there? SLS trial, right? 2006, the first SLS trial. So that peak also correlates with the IPF trials, which has increased in the last decades, utilizing FVC as a primary outcome. So that could explain why the CTD borrowed that primary outcome from the IPF trial. That's not an ideal extrapolation. IPF is completely different disease entity with different pathogenesis and different even clinical course. So what works best for the IPF is not or shouldn't be translated into other entities. Also, the use of SLS trial or to To look at this meta-analysis, actually 60% for these studies, which was around 75 studies, they did not mention why they used FVC as a primary outcome. The others, they stated we used it because it's more specific than the LCO. The others stated because it's more valid, and they failed to cite the articles supporting their claim. So, is FVC better than DLCO? It's a very well concept, even clinical practice. No items from PFT showed good sensitivity or specificity for early diagnosis of ILD. Be very mindful to that point. ILD, when it happens, it may not be severe enough to translate into lung function impairment. There is still room for the patient's physiology to accommodate the change in ILD. The other possibility is because you get a PFT of your patients who had a CT showing an ILD, and the number comes back as 90% of FVC. Is that important? Actually, no, because you don't know the patient's baseline. We know the baseline is a spectrum between 80% to 120. What about if the patient FVC had been 110 a year or a year and a half ago? So this is a significant drop from his baseline, which had not been and never been or will be captured by PFT as a baseline. Secondly, FVC as a good predictor of ILD severity is not sufficiently supported. So why it's still being used? As I mentioned, because of IPF trials. Secondly, there is no validation tests done. The SLS, indeed, they have what we call perceived validation of FVC. And since then, the majority of the trials used FVC, not the TLC or DLCO. This is a perceived, this is an overestimation of the utility of FVC. Because if you look at the numbers or how it was actually validated, it's because how it affected the treatment. Okay, FVC improved, so the treatment is working. Subsequently, that's a validation test. That's not correct. Validation means you would test the outcome or the measure of interest against the gold standard tests, and then you measure the outcome of 1, 2, 3, 4, and that's never been done. So extrapolating the fact that FVC is okay to be a primary outcome because it's showing the improvement and the effect of treatment is not practical. And apparently this is what has led to, if you look at the majorities of FVC trials, the improvement is not impressive, right? It's a modest improvement, always modest improvement. Take it with caution. Maybe because that's the reason they choose the incorrect or inappropriate primary outcome to test their medication's effect. Also, there's an arguable talk between FVC being more specific to ILD and DLCO more sensitive. Why it's less specific, the DLCO? Because it's being affected by other pathologies such as pulmonary hypertension. But that shouldn't be devoted from it being able to be tested as a primary outcome. We can do echocardiogram, we can do a 6-minute walk test, and even CPET to exclude the possibility of PAH, and then we say DLCO can be a primary outcome. And I will show some data supporting why DLCO is better than FVC for that. Secondly, the FVC reproducibility, it's thought to be more reproducible, and DLCO is more variable. Again, I'm going to show on the next slide that's not actually accurate or completely accurate. And interestingly, the FVC, the minimum clinically important difference for the trials was up to 3.3% of a change in by minus in FVC. And this is actually falls into the patient's range of measurements error, inter-individual variabilities. So also the FVC is quite variable. It's not only the DLCO. So this is a very nice, I would say, يعني رايق ما شاء الله اللي سوى هذه study. Recently published. They assess the reproducibility and reliability of FVC and DLCO in scleroderma patients. All what included here were SSC patients without ILD and patients with ILD but provided to be stable. They assessed the DLCO and the FVC at time 0 and 3 hours later to test and retest reliability. And then at day 15 and day 30, you can see they're not bad. Neither the FVC nor the DLCO. It's a small study, but it's good that it gives us that no longer the variability and reproducibility of FVC and DLCO should be an issue. At least we have to do a more prospective trials to address that point. And this is the forest plot. If you look at the sensitivity and specificity of few trials, look at the composite endpoints of using FVC, DLCO, or including even the TLC. The sensitivity and specificity is increased by the use of the primary or the composite endpoint. And that's something very interesting to think of. By getting more trials in the future, why not include a composite rather than single outcome measures? PAH screening in SSC, and it's going to be elaborated more in the afternoon sessions, but it's been observed that an isolated reduction of DLCO, a baseline being less than 55%, without significant ILD, and a ratio of more than 1.6 for FVC to the DLCO, were forecasting a future PAH patients in patients with SSC. But I'm not going to explore more in that part. Okay, so that's the early detection of lung involvement. What about monitoring the disease? You found an ILD, you started monitoring your patients with PFTs. You would do that because you're going to do a serial PFT monitoring, integrate the image, clinical symptoms, and incorporate biomarkers. Never rely on a single tools to assess your patient's response to therapy or monitor. Don't tell the FVC is declining, I would take an actions. You have to look at clinical pictures and imaging. At least 2 of these 3 have to be changing in a positive or a negative way to take an actions in changing your patient's management. Okay, so we've done the screening talk. So what about the follow-up? Your patient has an ILD now. Would you monitor them with FVC and DLCO? Well, in the follow-up, the extension of ILD on CT was associated weakly with FVC and DLCO decline. And actually, the DLCO better correlated with images than FVC. This is a nice linear mixed model graph. Evaluated the trajectory of FVC and DLCO throughout the course of SSC-ILD. You can tell without looking in the numbers that the FVC has a relatively horizontal line. The patient has a progressive radiographic changes, but the FVC is not changing. And even the progression-free survival here, which is defined by a decline in FVC by more than 10%, is not quite similar to what we see with DLCO. And DLCO reflecting more of the changes that's observed in chest images. In the census trial, which studied nintedanib in the patients with scleroderma ILD, the extent of fibrosis and lung function decline database and analysis, you can look at the extent of fibrosis at baseline, and they look at the trajectory and change in FVC at 52 weeks. In the placebo and nintedanib group, in the placebo, there is an inversal relationship between the extent of fibrosis at baseline and how the FVC declined. This is very concerning because clinically, when I see a stable FVC, that doesn't mean I do not need to repeat HRCT. We're not talking about screening now, about monitoring. So in practice, in ILD in general, not only in CTD, we repeat CTs after initiating treatment to document the relatively new baseline. I would like to see what my patient's ILD is doing after I do the treatment. But in SSC ILD, maybe it's more supported by that evidence. Do not rely only on the clinical symptoms or FVC. Look actually at the new radiographic changes to document actually if the patient is progressing. Also, another analysis combining the SLS1 and SLS2, the DLCO changes, reflect. The DLCO changes when they looked at the quantity of lung fibrosis in a zonal section of the lungs and the whole lung sections, and they found a strong relationship between the decline of radiographic abnormalities, and that translates into the DLCO. So DLCO, perhaps, based on this evidence, is better than FVC in monitoring the disease. And this is another graph. If you look at the area under the curve for the patients, the solid line is the DLCO at 2 cutoff, less than 80% or more than 80%. And the dashed line is the FVC. And that is showing that the DLCO being less than 80% has a good predictive capability of identifying, with a good sensitivity, in identifying abnormal CT at 2 years. So if you follow your DLCO and the patient started to decline 3%, 5%, 10% during 18 months, for instance, and he doesn't have a PAH that's progressing, think about that. He will progress radiographically in the next 2 years or during the 2 years. Another important point is FVC showed high variabilities, right? And the fast decline experienced mainly in the early disease. So that's one of the well understood prognostic factors in SSc-ILD. And that's well illustrated in USTAR database. You can see that it's very scattered, the course of FVC, but that does not translate into the actual course of the patients, neither in clinical situations nor in the radiographic findings. What about predictions of mortality and progressions? DLCO again is the best than FVC in that regard. It was most consistently associated with mortality than FVC. Decline in DLCO, the most predictive of adverse outcome, especially mortality. And the 1 year trends in FVC and DLCO composite. Again, this is the good rule of composite endpoints. And the 2 year trends in the measure of DLCO are more predictive of mortality. You can see more figures in here. You can see that the FVC at the baseline, the lowest it's been, the worst survival in the short and medium-term mortality curve. And based on a lot of previous studies, we know that the presence of a low FVC is associated with worse mortality, as well as a presence of declining or a low baseline DLCO. So what about TLC? It's never been studied and was in the past as a secondary outcome, and it fell off the favor. To be honest, even in ILD, not CTD's ILD, we don't pay attention a lot to the TLC, although the guidelines of the American Thoracic Society relies on TLC being as a hallmark for restriction. But we don't use that to monitor the disease course. In my opinion, because of lack of evidence or lack of initiation to consider that as a considerable primary outcome for ILD's trials in general. But what about the treatment efficacy? Why would we repeat BFT? The patient started on tocilizumab and she's fine, stable. Why would I repeat 3 months or even 6 months interval for that? Because I would like to assess if the patients change their physiology based on the treatment I initiated. I sometimes adjust treatment plans, but again, recall my words when I said you have to incorporate it with clinical and radiographic changes, at least 2 out of the 3s, assessing the treatment efficacy, and identify treatment-related complications. Sometimes the patient's been on methotrexate, right? And the rheumatologist claims that methotrexate, now the patient got a new ILD. Should we continue that or hold it? You would continue your patients on methotrexate if it's mild to moderate, not the severe ones, but you have to monitor that to make sure it's not the culprit, although you cannot confirm that with 100% accuracy, but at least to monitor if that's really a side effect of methotrexate. Minimal clinically important difference, which means the FVC changed in the trials. What's the cutoff for that change being clinically translated into a good outcome? Either the CT تحسنت, the patients feel better, or the patient's reported outcome have improved. So in the OVERACT working group, which was a very good initiative from them in 2005, they proposed MCID for the CTD-ILD being a decline in FVC by more than 10%, or less than that if it's associated with a 15% decline in the LCO. In looking at the SLS1 and 2 trials, as I mentioned earlier in my talk, the MCID was reported to be an improvement in FVC from 3% to 5.3%, or worsening -3 to -3.3%. This is a very tricky number because, again, as I mentioned, it might fall into the inter-individual variability of the own patients. If you do your own FVC and you repeated it a month later, it might fall into this normal range, relatively normal range. So we are, as in pulmonology, we follow the progressive pulmonary fibrosis criteria by the guidelines, international guidelines, which the patient should have at least 2 out of the 3 changes in their lung status, worsening respiratory symptoms, or an impairment in their physiology, either the FVC declined by more than 5% or 10% with DLCO, or there is a radiographical evidence of 1, 2, 3, 4, either inflammatory or fibrotic changes, and 2 out of 3 is needed to label your patients as a PPF. So finally, I have no room to talk about the other ILDs. It's CTDs, related ILD PFTs. It's a very extensive list, but there is no validations, and if it's no validation for SSC ILD, let alone the other ones. But just رفع العتب, there is some evidence to support the utility of different PFTs in different outcome for others than SSC entities, such as rheumatoid, Sjogren's, idiopathic inflammatory myositis, and so on. So the challenges and limitations and variability, as I highlighted it, be careful to that. No specific findings. If I find FEF of 25% to 75% decline, it's not specific to our population, let alone to CTD populations. Patients' compliance and effort is very important. My practice, when I noted a decline in PFT, I repeated it 3 to 4 weeks to document sustainability of the results, because there is quite effort-dependent results when you repeated the tests. Resource and accessibility, it's a huge burden in some of the centers still. في نقطة very important, which is now it's more common in the pulmonology literature, which is the use of the Z-score in grading the severity of PFTs. The Z-score is calculated by subtracting the predicted value from the actual number. So your patients, based on his age, height, and gender, should be having FVC of 3.5 liters. He produced 3 liters. You subtract that, and then you divide it by standard deviation, and there is a grading of severity: mild, moderate, severe, starting from 1.64 as a Z-score. There is a paucity of literature about this. It's a relatively new entity, but I found interesting, maybe 5 years ago, in scleroderma population, they looked at the Z-score specificity for findings of lung fibrosis. If you look here, the white circle is the patients with scleroderma and no ILDs or PAH. The light gray is the patients with PAH. The dark gray with both PAH and the open is clear. The light gray is ILD. Dark gray is PAH, and the black is the combination of ILD and PAH. The end results for this graph is a specificity reached 100% when they calculated the Z-score of FVC and TLCO in finding a lung fibrosis. And they used the cutoff, as I mentioned, of 1.64, which is equivalent to less than 80%, the number that we're currently using for grading of severity. Sorry. The biomarker development, genomic, proteomic insights, technological innovation is not going to be seen a lot with PFT. Simply speaking, because that's not going to get a lot of financial rewards. So all the fantasy coming up in the evidence-based medicine, we're going to find some delay in implementing it in the lung physiology. And that's my conclusion for today's talk. So interpreting PFT should be in the clinical scenarios. No robust validation studies about the PFT parameters in CTD-ILD endpoints. FVC is sensitive, DLCO is specific. So that's a typo I found last night, the reverse type. So FVC is specific, DLCO is sensitive, but I didn't want to bother the organizer by resending them the slides. And I wanted to see who's concentrating during my talk. And both are good for prognostications, and we talked about the challenges in PFT. Shukran jazeera.